I'm Daniela Carusi. I'm an obstetrician gynecologist at Brigham and Women's Hospital, and I'm the director for the program for Surgical Obstetrics and the Abnormal Placentation program. We take care of quite a few patients who are expected to have complicated cesarean sections or who are at risk for hemorrhage at the time of delivery, and that includes patients with abnormal placentation or placenta accreta. Ultrasound is pretty good at diagnosing accreta, particularly if we know that a patient is at risk for an accreta, and also particularly if she has a placenta previa where the placenta is sitting directly behind the bladder. In that case, we can often see if the placenta looks abnormal or has abnormal blood flow. It's a little bit harder to diagnose with ultrasound in situations where the placenta might be on the back side of the uterus, or if the accreta is happening in a situation other than a placenta previa. Even in the best circumstances, an ultrasound is not perfect at diagnosing an accreta, so there will always be situations where a patient at risk for an accreta has normal ultrasounds, but some of them still end up having a placenta accreta at birth. And there are situations where the patient has an abnormal ultrasound that looks like an accreta, but her placenta actually delivers without problems when she comes to have the baby. In situations where the placenta is occurring outside of a placenta previa, it's much more difficult to diagnose with ultrasound, and it's important in those situations for the radiologists or the people doing the ultrasound to know that the patient is at risk and to take a careful look at that placenta. Some people will order an MRI in order to help make the diagnosis. In some cases, it can be helpful. So if the ultrasound is not a very good quality ultrasound, for whatever reason, it might be an anatomic issue, or if the placenta is not a previa, so it's not in the perfect place to look with an ultrasound, then an MRI can sometimes be helpful. It also might be helpful if we think the patient may have a placenta percreta, and we want to look more carefully at the interaction between the placenta and the bladder, and sometimes the MRI will give us that information. If a patient has an ultrasound suggesting that she might have an accreta, or even if a patient is felt to be at very high risk for placenta accreta, she should be cared for at a center that takes care of placenta accreta on a regular basis. These are often referred to as centers of excellence, or might include tertiary or academic medical centers that take care of quite a few high-risk patients. But all patients with an accreta, whether they're bleeding during the pregnancy or have a previa or just have an accreta, need to be at a center that can plan a delivery that's going to be more complicated than normal. Prenatal care for patients with a placenta accreta can be quite normal. So the delivery planning is the part of the pregnancy that's the most complicated and requires a high-level center. So we certainly have patients who receive their regular prenatal care with their primary obstetrician and then make visits to the tertiary medical center in order to work on delivery planning through the pregnancy and then come to that center to ultimately have their delivery. The biggest risks for patients with placenta accreta happen at the time of delivery. And the first is the risk of hemorrhage or major bleeding at the time of delivery. And this can happen if the placenta is abnormally attached and we try to remove it. There are very large blood vessels that go into the placenta, and when these become exposed while we try to remove the placenta, then the patient can have very excessive blood loss or postpartum hemorrhage. And this often requires blood transfusion, often with many units of blood products. Sometimes we'll actually be set up to collect the patient's own blood at the time of delivery and retransfuse it because the transfusion risk is so high. Also, because the placenta doesn't detach at the time of delivery, and because trying to forcefully detach it can create a hemorrhage, we often have to perform a hysterectomy in order to remove the placenta and in order to allow the patient to leave the delivery without a hemorrhage. And that means delivering the baby through the uterus, and then instead of removing the placenta, removing the entire uterus with the placenta inside. When we do that, we'll always try to leave the ovaries so that the patient doesn't have to undergo an immediate menopause, but she will come out of that delivery without the ability to carry more children. So in most situations, a confirmed placenta accreta is managed with a hysterectomy because that's the only way for us to remove the placenta safely without creating a major hemorrhage. However, as you can imagine, there are many patients who want to avoid a hysterectomy, and sometimes we as surgeons want to avoid a hysterectomy because in certain situations like a severe percreta, or in certain patients who have an abnormal pelvis, doing the hysterectomy might just be considered too dangerous at the time of delivery. So in those unusual situations, we might leave the uterus behind, and that's referred to as conservative management of a placenta accreta. The major downside of conservative management is that we're actually leaving the placenta attached to the uterus at the end of the delivery and leaving it inside of the patient. And as you can imagine, many patients don't want to go home knowing that they still have their placenta attached. Patients who have this done are at risk for having bleeding, and that sometimes involves heavy bleeding even weeks after the delivery. And some of these patients can develop an infection with the placenta inside of their uterus. So it's particularly important for the patient to be well counseled and informed about the risks and to follow with doctors who understand what it's like for a patient to be in this situation and know how to follow a patient and take care of the placenta. Sometimes we're able to go back a number of weeks later and remove the placenta without any hemorrhaging, and sometimes that placenta will fall out weeks or even months after the delivery. A patient who comes through a pregnancy with placenta accreta and has not had a hysterectomy, either because she intended conservative management or just because she had a small accreta and we were able to get the placenta out at the time of her delivery, she'll still have a uterus and she'll still have the potential for having more children. And many patients in that situation do want to consider having another baby and have a lot of questions about the risks involved. The biggest risk for these patients is having another placenta accreta, and many of these patients understand what that means because they've already come through a delivery with one placenta accreta, but they still need a lot of counseling about the risk of hemorrhage and the risk of hysterectomy if she comes into another delivery and is diagnosed again with an accreta. The chance of that happening, according to research that we have available, is about 25 to 35%. So there are many patients who go on and have another pregnancy and have a very safe delivery and don't hemorrhage and don't have an accreta. However, we want these patients to all seek care in a center that understands their history and understands their risk. We'll take a careful look at the placenta during the pregnancy, and then we'll always prepare for the delivery knowing that the patient is at risk for an accreta and is at risk for a hemorrhage and potentially needing a hysterectomy. But when all of those conditions are met, some patients feel it's still worth it to go ahead and have another pregnancy, and some are willing to undergo a potential hysterectomy just knowing that they can have one final baby. The recovery after a delivery with placenta accreta really depends on what happened at the time of delivery. The hardest situation is when the patient and her providers didn't know that there was a placenta accreta because it didn't show up on any imaging beforehand. In that situation, sometimes the patients have an unexpected hemorrhage at the time of childbirth and may require extra procedures in order to manage the hemorrhage or require a blood transfusion. Occasionally, those patients require intensive care immediately after delivery, and that's going to prolong her recovery. For patients immediately after delivery, it can mean staying in the hospital for a few days longer than normal, or sometimes even longer than that. Following the childbirth, the patient might just feel a little traumatized, both physically and psychologically, from having undergone a difficult delivery. So it's important for these patients and their families to understand that both physically and psychologically, the recovery might be a little bit longer and a little bit more difficult. It's important for family members to work with the patient and identify if she's not doing well postpartum so that she can get close follow-up, either with her obstetricians or sometimes with a mental health professional if she's having a hard time coping with the complications. Delivery timing with a placenta accreta is actually a fairly complicated question, and it really depends on the patient's particular circumstances and what type of a placenta she has. Specifically, that means whether she has a placenta previa or doesn't have a placenta previa. Most of these patients do have a placenta previa, and all patients with a placenta previa need to be delivered well before their due date, usually about 3 to 4 weeks before their due date. And that's because we need to have the pregnancy delivered well before the patient goes into labor. We want to avoid labor for these women. With placenta accreta, we have to consider both the fact that she needs to avoid labor and the fact that her delivery is going to be more complicated and is going to require a prepared team of surgeons. So because of the need for extra preparation and a strong desire to avoid an emergency or unplanned delivery, we'll often deliver accreta patients even earlier, and that can be as early as 34 weeks or sometimes 35 weeks during the pregnancy. There we have to balance the risk of cesarean section and hemorrhage and need for a special surgical team against the risk to the baby of being born up to 6 weeks early. But if the mother is going to have an emergency delivery, that's also a risk for the baby. And so we're considering both the mother and the baby in delivering that early. Placenta accreta is actually not a direct risk to the baby. It's much more of a risk to the mother. So babies that are growing in an environment with placenta accreta will grow normally. They're fed normally with the placenta and tend to do very well. When the mother has a placenta previa, similarly, the babies tend to do very well. But if the placenta previa bleeds during the pregnancy or if she experiences a hemorrhage during the pregnancy, because it's dangerous to the mother, it's going to be dangerous to the baby as well if the mother doesn't get the correct help. Placenta accreta is obviously an overwhelming diagnosis. Patients who are diagnosed with this condition have never heard of it before, and many of them have never even imagined that something that severe can occur during pregnancy. And oftentimes they're diagnosed with a doctor who has very little experience taking care of placenta accreta. It's important for you to know that if you're getting care in the right facility with doctors who take care of placenta accreta on a regular basis, if your delivery can be planned, if your care can be well supervised, that you can deliver in a safe environment and that you can come through your delivery with a healthy mother and a healthy baby.